Thank you, Paul. Good afternoon, everybody, and welcome to the webinar on short and long-term implications of COVID-19 on patient engagement and advocacy. Now, situations like COVID-19 can be split into three phases. Really, there is the first initial, the shock phase, where people are wondering, well, how is it going to affect me? The fear stage. Then really moving on to the acceptance stage, it is what it is, before then going into the final stages, which is the transitioning into the new norm, and where people realize that the new world is not the same. So where is patient advocacy and engagement? Well, to help us answer this question, an expert panel from clinical research, patient groups, patient advocates, and European health policy has been developed for today to attempt to answer these questions. I'm Nick Hicks, the Director of Commuter Advocate Communications, and I'll be facilitating today's workshop. Now, just a quick introduction to the panel. Dr. Albert Ferrugia is a respected biotherapeutics consultant who is also a patient rights activist and also is a sufferer from a rare primary immunodeficiency, and he's currently locked down in Italy. Pedro Carrascal is the president of the European Multiple Sclerosis Platform and the CEO of the Spanish group, Spanish MS group, and is currently locked down in Bilbao. Gareth Powell is with the National Institute of Health Research in the UK, and he's the Business Development Officer, and he supports life sciences to engage patients with clinical design. He's locked down in the UK. And Tamsin Rose, who's a European health policy consultant, currently locked down in Brussels. And there's also Paul Copcott, who's behind the scenes to ensure everything runs smoothly. Now, there's no slides. The format's going to be very simple, is that I'll be asking each of the four experts to give a 3-minute overview of their understanding of the short and long-term implications of COVID on patient engagement and advocacy. There will be questions as well from the floor. I've also got questions from people who unfortunately couldn't attend, so I'll be asking the panel those questions. The meeting is being recorded. A report will be coming out, and we would love to hear your feedback on the event. So when you do exit the webinar, there's just 2 simple questions, and it would be great if you could answer them. So without any further ado, I'd like to pass you on to Albert Ferrugia. Thank you, Albert.
Good morning, good afternoon, good whatever time it is, wherever you are. I have to tell you, this is my first webinar, so excuse my nervousness. I'll clarify, first of all, a slight detail about myself, and that is that I'm not a member of the primary immune deficiency community, although I support it strongly and as much as I can. I'm a member of the bleeding disorders community of people with hemophilia. In my professional work, as well as in my academic activity, I'm observing this phenomenon, this historical period in which we're all immersed, and obviously reflecting on the way in which it affects myself and my work. And I want to kick off by making briefly 2 points for patients to consider in areas which I think are immediately relevant to them. All patients with rare disorders are immensely interested, of course, in the scientific literature, which reports on medical advances and scientific developments in relation to the areas which affect our lives. And in the current era of the COVID-19 epidemic, we have a vast literature which has very altruistically been made available free by the main medical publication houses. This literature is being made available very fast without rigorous peer review as we are used to it, those of us who publish, which takes months and months. Those who, like me, have an active publication activity are frequently frustrated by this. It is the case that we are getting a lot of scientific information very, very quickly and very, very cheaply, but I would just like to warn people about the need to be very much aware that what is being provided has not been peer-reviewed. And there have been some instances already where discussion has shown that some of the information imparted has not exactly been accurate. This, I think, is important. Equally important and somewhat linked is the area of clinical trials, and this is going to be imparted to you in more detail by another speaker later on. But I would just like to make the point that, as in everything else, things in the area of clinical development are moving very, very fast, which is something which we rejoice at. We are seeing enormous flexibility from the regulatory authorities. We're also seeing a remarkable level of cooperation, at least in the space which I occupy, in the industry itself, with companies cooperating in developing treatments. These are extremely good developments, and we welcome the adoption of the current clinical trial framework to provide treatments more quickly. A word of warning here as well: the development of this clinical trial framework for many, many years has not been out of caprice. It has been out of the need to assure efficacy and safety of drugs, and we must remember that in abbreviated pathways towards access, which is what we're dealing with now, these have been somewhat curtailed. I think this is something which should interest patients. It should not unduly concern them, because the regulatory authorities are still very much in control. But I think that, linked again to the issue of what is published, this is something of relevance and of potential concern. I think at this stage, Nick, I've used up my 3 minutes, so I'll pass over to you.
Thank you very much, Albert. Pedro, over to you. Short and long-term implications.
Okay, thank you, Nick. Thank you, everybody attending the webinar, for the opportunity to underline and make more visible the patient organization in this webinar. For sure, this crisis of the COVID-19 has been a great opportunity to show the value of the patient organization. Probably today more than ever, this could be underlined. First of all, because of the advocacy area or added value of the patient organization. Everything has changed, everything has been blocked. This is the extraordinary great opportunity to advocate for the new circumstances. First of all, about information, about sharing data, about new consensus. A lot of new things should be done, has been doing during this last month, and the patient organization has been playing a clear role on that. A new cards on the table of the game, and the government has been all the governments around Europe, around worldwide, has been making steps. So we have been involved in not letting the people with MS, for example, in our example, out of the new puzzle, and every time the thing has been moving, we have been putting the needs of the people with MS, on the patients, in the center again. So advocacy is one of the highest value things during the crisis. And of course, as I said, information, the lack of information is tremendous. New registers should have been put in place, and we have advanced a lot. We can talk later about that, about the great opportunity during this crisis of sharing data and putting the pros, also the patient-reported outcomes on the table. But the rest of the stakeholders probably have been more blocked. For example, the health system and others, and the central role of the patient organization inside of in the middle of on those stakeholders. For example, between the health system and patients, between neurologists or doctors with the patient, also dealing with the pharma companies and trying to work with them in all of this. It's just the first and the first thing that I would like to underline before the next conversation. Of course, these are some terms implication, advocacy issues, information, consensus, so on. But in the future, I see the opportunity also of improving all those things connected with this data sharing, for example, and the participation of the patients in the patient engagement in a new era. Probably we have been talking a lot about this, but the patient should be more coordinated inside of the health system, not only during sometimes in the process during the visit to the hospital or whatever, but also in a daily basis. So I think that in more long term, that was I want to say with you.
Thank you, Pedro. We'll obviously have a lot more time to go into some of those individual points. I'd like to pass on to Gareth now, please.
So I think one of the key things we're going to be seeing is a big change in culture. That was picked up about the collaboration which we're seeing with the life science industry, working very closely with one another, but also about the culture change in patients themselves. We're going to see a much higher uptake in interest and potentially even understanding of clinical trials effectively. We're all effectively now patient advocates. We're all looking for that vaccine coming through or a potential treatment which will end the various lockdowns we're seeing at the moment. Likewise, the media's appreciation of clinical trials and of the life science industry is a big change at the moment. Even Donald Trump, for example, who was originally vilifying the life science industry as villains, has now changed completely to saying they're heroes and geniuses effectively. So that's going to have a trickle-down effect. Likewise, we're seeing individuals who are using online platforms like Zoom and Skype and what have you. For example, I've been speaking to my parents using their tablet and my tablet. As we move towards the uptake of virtual clinical trials, we're going to see a much more readily embedded technological understanding way of working, both with their own healthcare providers, but also with regards to enrolling into clinical trials. I think the rapidity of what we're seeing, this isn't normal at all. We use the term a new normal, but it's not normal. This is an exceptional situation effectively. But that change is going to have quite a major effect. And as the rapidity of the setup of trials, we're saying, well, can we keep doing this? Potentially, I think the risk is the good steps we've made with patient involvement and patient engagement, we can't lose that as we move towards this, potentially move towards that new model. We want to ensure that that carries on and we continue collaborating, not just within industry, but also with patients and patient advocacy groups as well.
Okay. Gareth, anything else? You've got plenty of time left. Or is
okay,
that good? Yeah, you're okay. I've got my little timer.
Great stuff. Yeah. Plus, I think, Pedro mentioned this as well, there's going to be a lot of input required by patient advocacy groups as we get more kind of interest and uptake for clinical trials. Accessing the right information is going to be very, very important. But likewise, at the moment, we realise the funding streams available to these patient advocacy groups is at risk, unfortunately, which has an impact on research being coordinated by these groups. But likewise, the focus of research at the moment is very much on COVID-19 and public health trials. So we're moving away from potentially underserved groups. Hopefully in the long term, as we move towards, let's say, virtual clinical trials again, we're going to increase the accessibility, the ability for people to be involved, both in clinical trial design, clinical trial output, but also about the objectives of the life science industry. We'll hopefully get that patient voice much more embedded in trial design. As I say, there is that risk, I think, that we could lose that if we're not careful.
Okay, thank you, Gareth. And Tamsin, over to you.
Thank you very much. And in building on what some of my colleagues have said, I think this issue of health literacy is critical. For a long time, it's been a niche part of health policy, and suddenly everyone has had to get up to speed on issues like flattening the curve, understanding the basics of, epidemiology, the question of transmission rates. Suddenly everyone's talking about them. So I think in order to get the population to follow the lockdown measures, there needed to be a greater understanding both of, what a disease is, how can it be transmitted, what your risks are, the difference between a virus and a bacteria. All these kinds of information has had to be put out into the public domain and get people to understand it in order to change their behavior. So I would expect to see quite a big focus on this area, which is a key area for patient engagement, working with patient groups, helping them to understand their disease, helping them to understand what conditions they can live under, how they could live more healthily, how they can follow their treatments, how they can talk to their doctors. So I can see there's a good connection there between this broad approach on health literacy and the work of patient groups. I think one other area that will be easier for patient groups in the short term is that for a long time they've been trying to make the case of what is the socioeconomic impact on them and their families of living with a condition. And guess what? Everyone's in lockdown. Everyone has just really got the message of how difficult and frustrating it is if you can't get out, if you can't move around, if you're not able to do your normal social activities, if you can't work. So I think the case of the impact economically and socially on an individual or their family of what it's like living with a condition, that message will resound much more clearly with audiences because they've just been through a process where they have found themselves unable to do the things that they would normally do and realize what this means to their connections with their family and with their friends, their ability to engage in everyday life. So I think that's one area that's of interest. Another one is that we go out and we clap for the carers. And the carers, in the way that it's talked about today, is frontline medical staff. But there's also been a broader understanding when we talk about people who are vulnerable populations isolating at home, that there's an enormous army of hidden, unpaid and unseen carers who are families taking care of patients with different diseases. So that I think there's a new focus that patient groups can build on the role of carers, how critical they are to the well-being of people. And this leads me to the final point I wanted to make, which is that there is going to be, again, a new interest in the issue of mental health, that it isn't just about physical health, it's about the impact of what happens if people are unable to go out and do things and work and contribute and be part of society. And the long-term impact, I've seen people talking about concepts like social scarring, that the fear of the pandemic, the impact of being locked down, the loss of jobs, the fear for the future is going to leave social scars on people. And we would expect to see people with long-term trauma concerns about this. So I think there's a number of different areas that the COVID lockdown, some avenues that are quite positive for patient engagement to pick up on. Nick.
Thank you, Tamsin. Now, I've had a number of questions already coming in live. And what I'm going to do is I'm going to switch between ones I've already been previously asked and some of the ones that have just come in live. So, Pedro, I have a question for you from a European patient group perspective and from a national patient group perspective. Where do you think patient groups are at the moment regarding their management of the situation? Are they still in the early shock stage, or are they in a transition or on a transition stage?
Okay, thank you, Nick. Well, I see here three scenarios, not only one, because we are facing different situations. We are facing the situation of the advocacy. We were talking previously about the information consensus, the data registry or access to treatments, for example. But we are also facing some issues about the service provided to the people with MS or to patients in general and the quality of life. And of course, we are facing the economic and financial impact of the crisis. So in every different scenario, we are in a different states. We are still working in the advocacy issue. I have seen in the questionnaire, in the Q&A tool, that there also has been a comment about the advocacy role of the patient organization. Yeah. So I would like to say that I am not talking about the decision making process. Of course, probably the Ministry of Health and the new teams and the new roles have been created, new decision process has been created. But in any case, the role of the patient organization has been to provide information, to put on the table the needs of the people with MS, to put pressure on how it needs to be resolved. And of course, we have been working and gathering information with the rest of the patient organization, for example, in Spain, through the Plataforma de Paciente, the POP organization, and we have been sending letters to the ministry and to the crisis cabinet talking about what was the need. We have been making surveys, we have been calling the hospital, the doctors, the pharma companies. So the role is clear. Probably we have for sure we have not been involved in the decision process in those moments, but we have been reply weeks after and say, okay, we were reading your letters, we have been taking notes of what we just saying. So I think that is being in the process and representing the needs of the people, of the patients. In any case, there are different states, and the next states will be the economic and the financial issues, of course, and how we can adapt and be more flexible with the providing of services for the patients.
Okay. Pedro, thank you. Albert, a question which is just coming with, which just follows on from what Pedro was saying. And perhaps it's best shared between perhaps you and Tamsin. What is the role of patient groups to ensure that clinical trials are being conducted, have a solid scientific basis and are ethical?
I think, and you know, my main involvement is with the bleeding disorders community, where I am very much aware that as a result of the advocacy efforts of the past, you know, quite a few years now, many patient representatives are actually embedded in those areas of regulatory affairs where you actually have an opportunity to have a say. I know that regulatory authorities such as the US FDA, several of the Union authorities, the Australian authority, all have committees in which patient representatives, so-called consumer representatives, are also put in. So I think that there's already a very good grounding of infrastructure. As a result of what we're going through at the moment, I think that this is going to accelerate by leaps and bounds. I think that there's going to be a very rapid appreciation of the fact that in order to facilitate and accelerate a clinical development wherever it is possible, it's going to have to require a very marked patient input. Because otherwise there is not going to be a sharing, an appropriate sharing of the responsibility. We have to appreciate that what we're looking at now with clinical trials is actually a substantial paradigm shift. And in terms of the sharing of the responsibility, traditional regulation has involved the sharing between the regulatory authority and the industry. I think that with the inoculation into the system, if you like, of more rapid and different pathways towards rapid approval, that responsibility is also going to have to be shared with the patients. And if that is not going to involve representation, it's not possible.
Thank you, Albert. Tamsin, do you want to add anything to that from a literacy perspective?
Yeah, I do, which is, I think the first thing to say is traditional clinical trials or randomized control trials are complex things. They're not like going to a kitchen and saying, oh, I'll add in a few more ingredients into my recipe. They take a long time. There are ethics committees that need to be dealt with. There are criteria for patients for eligibility, etc. So to be able to participate, for patient advocates to be part of that in a meaningful way, they've got to already have quite a high level of understanding of health terms, how the health system works. They need to understand confidentiality issues, trust issues, ethical boundaries. So it isn't, I think, an easy case to say COVID is going global. It's affecting people all around the world. We've got clinical trials happening everywhere. We can suddenly bring lots of patients into those types of trials, because the trials that I think we've got going on for COVID-19 are emergency trials where doctors are just trying anything that they can. They're learning as they go along. Information is being shared very rapidly. It's very different from a kind of gold standard, carefully developed clinical trial where you would be comparing a new drug against existing treatment. We don't have treatments. COVID is a brand new disease. So I think it's a different perspective. I think the existing patient advocates who have experience of clinical trials would be extremely useful to be brought into the process, because they can bring their knowledge, their historical understanding, their ability to provide input. I don't think anyone can be considered an expert patient on COVID-19, because even those who've been through it, what we understand is everyone's experience is very different. Our knowledge of the disease is growing very quickly. Now we understand it affects more organs of the body. It's no longer just a respiratory infection. It affects the brains. We're seeing kidney failures. So it's an area where traditionally a clinical trial would be around a specific disease for a specific drug. COVID-19 has opened all of that up. And we're not just trialing treatments, we're trialing how a hospital is organized. We're trialing triage. We're trying public drive-in testing. So we're in a completely new area for clinical trials with this disease.
Just to add that, Nick, if I may, sorry.
Yeah, I was going to say jump in, Gareth, because I think this is right up your street on capitalising on what we've already known, and with the, I'll leave it up to you. Yeah.
Part of the challenge of this, which kind of has been alluded to as well, is obviously some of these trials are being conducted in people who are in intensive critical care units, effectively on ventilators. And one of the issues we have is consent for this. If they're being moved to separate units, for example, how do we trace them through the system? We've got PIs in very difficult situations, and likewise, we have families who are in very difficult positions as well, because their last moment with that relative or family member, whoever it may be, will simply be then brushed out the door effectively into an ambulance, and they're not able to go and visit them in hospital. It's very disconnected. So we need to be very, very conscious of this when we're actually approaching individuals to provide consent on behalf of that individual. So we're looking and exploring new ways of how we can do this, but it's, as Tasman mentioned, it's very different from bringing a patient voice in regards to identifying what are the quality of life outcome measures compared to standard clinical measurements, for example. How do we integrate those two together? So having that different tiers of expertise, we're still very early on in that process. It's still very rapid. This is a catalyst for innovation and new ways of working. But it's how do we embed that voice to make that easier when we, as say, everyone is effectively now a patient advocate of this. How do we tie the two together? We're still in unknown territory largely.
Okay, I've got a question from Emmanuel. It's a general question. I don't know who would be best to, so I'll open it up to the panel. Is COVID-19, does it provide a great opportunity to promote registries on a global scale and even extended international collaboration amongst authorities, patient associations, medical bodies and governments? Quick one. Albert, what do you think? Quick yes or no on that one.
So, sorry, I was muted. The short answer to that is that I don't want to make COVID-19 the owner and responsible for all of the things which should be happening irrespective. Registries are here to stay. There are a zillion reasons for why they are doing things. I think we have to be wary of giving the impression that we are pushing everything on this epidemic. Having said that, I think that for the reasons already discussed, the epidemic can only accelerate the development.
Okay. Pedro, I know registries are a big thing in the MS world. Do you have a follow-up comment to Albert?
Yeah, I agree. This is an opportunity to accelerate the process, and I have seen during this month things that I didn't see before in years in Spain, but also worldwide. Things are moving, and the COVID registry could be used as an example of how we can accelerate the process for sure in the future. So I agree with the comment that things will be changed.
Okay. Does anybody else have a comment on Gareth? Tamsin.
Yeah, I think the importance of registries and the importance of sharing information is immediately obvious to everyone. I think the key question here is trust, because we already have a certain amount of competition between countries about whether their death rates are higher or lower. Countries are being compared to each other as a way of seeing, has the government done their job? And then other people saying, yeah, but we're not comparing the same things because the death rates are being measured in different ways. It's whether they're confirmed or tested. So what you have in the area of something as simple as tracking mortality, all of these other criteria and political issues coming in. Now, I mean, at European level, it's been a work of 10 to 15 years to get some registries in place, and it's still complex. Going global, and the importance of that's been shown to us from COVID, is going to be complicated by some of these political factors. So what COVID-19 has seen is what I would call political health diplomacy. So some countries are sharing information, they're sharing medics, they're sending equipment, they're branding the side of their plane, from this country to that country. So it isn't as easy as saying this knowledge should all be shared so that we can have a global good, because there are lots of other political reasons behind it. And I think although COVID has shown us we need to do it at global level, the challenges of doing that, I think, have just got a lot more difficult as a result of the political context of this pandemic.
Okay, thank you, Tamsin. I'm just going through some of the other questions. Now, again, this is more of a general question, I think, to the panel. How can patient groups be best supported at this time by the industry? And I'm talking CROs, pharma, medical devices. Okay. Does anybody want to give some insight into that?
Can I start?
Well, I think some pretty bread and butter issues, and I rejoice to see companies which I have an awareness of moving rapidly into the landscape. Bread and butter issues such as the supply of the medicinal products which chronic disease patients require. Given that we have this lockdown situation, given that access to hospitals is less easy, given that, in fact, life goes on for patients with chronic disorders and they do get mobility issues and they do get their health challenges, I see bread and butter issues such as the actual delivery of the product to be something quite important, not very glamorous, but I'm glad to see that there are companies who seek to be of service without necessarily seeing much glamour.
Thank you, Albert. Pedro, you had a comment.
No, you were asking about how we can support.
How can the industry support patient groups both on a European level and on a national level?
Yeah, I think the point there is to put as a stakeholder, not as only a stakeholder in part of the whole issue, but we are working in a different areas. We are only not a provider of information, for example. We are not only a provider of services. We are also, if we are not bypassing the patient organization and we are using them strategically, because if we are supporting in information issues or we are supporting in I don't know, in advocacy or where other parts, we are strengthening the organization and we are making a great favor for the future. So it's not only supporting economically, of course, it's very more than welcome from the governments, pharma companies and society in general, from individuals, because the situation is incredibly difficult for us, but not only supporting economically, but also supporting strategically. I would want to underline again, not bypassing and trying to use as a whole, not just using for this concrete purpose or those other purposes as a whole, because a lot of things impacting as an outcome of the quality of life of patients are provided by the patient organization.
Okay. I just want to ask a follow-up question on that, Pedro, is that how do you think, COVID-19 is obviously a devastating disease, but how are patient groups in other disease areas going to ensure that their healthcare agenda is represented at both the European and national level in the coming months when everybody's talking about COVID? I'll kick off with Tamsin, perhaps, on that one, because it may be a more policy-related question.
Yeah, I think, to be quite honest, that's going to be very hard, because governments are focused right now. They're still in emergency management mode. They're still trying to sort out, getting PPE equipment to the frontline workers and, managing the critical care situation. So I think the chances of being able to engage in a meaningful conversation about anything else is in the next 3 months, possibly next 6 months, is very limited. There will be a moment where that sort of emergency time set moves on, and there'll be a chance to reflect, and there'll be a lot of focus on lessons learned. What do we do right? What do we do wrong? And how are we moving things forward? And there is an opportunity to say, well, for patient organizations and patients who were recognized in this pandemic as being particularly vulnerable, what was the level of support? What was the role of patient organizations in helping to maintain these groups in security, to make sure their needs were met, etc.? And if we now understand that this pandemic is not going to go away, it's possibly going to come back, we're going to have more waves of it, it may become seasonal like flu, the importance of patient groups to help strengthen the resilience of people who are particularly affected for it, I think they will have an important place at the table to discuss this, because at a certain moment we're going to move away from how do we manage this first wave to how do we live with this? How do we deal with the fact that this is going to be coming back and back, and certain sets of people will not just be vulnerable now, they will be vulnerable again in the future, and new people will be moving into the vulnerability category, because there's some new research showing that, if you live in a polluted city, your chances of getting a serious version of COVID-19 were higher than if you had lived in a less polluted area. Wow, that creates a whole new set of vulnerable people. And patient organizations, with all of their skills and knowledge, have things to offer in that conversation.
Thank you, Tamsin. Cool. Gareth, I've got a specific, they're quite related. Firstly, what is the NIHR doing to facilitate patient engagement? And I've had a question from Thomas, who's a patient advocate. He wants to get more involved to add value in the UK. So how, briefly, how would you respond to that?
I'm going to tie that into the previous question as well, if I can. So at the moment, for example, the UK and the NIHR is focusing very much on the delivery of COVID-19 urgent public health research. Other trials are being suspended effectively. Life science companies are putting these on pause because there isn't necessarily the resource and interest to, or the capacity to deliver those clinical trials. So in the long term, as we start hopefully being able to open up these trials to start delivering those, I won't say standard clinical trials, but non-COVID clinical trials, for example, in long-term conditions, I think the life science industry is going to have to find a way of both raising awareness and also the accessibility for these individuals, especially these at-risk groups, to be able to participate in those clinical trials. And that's where the conversations with these patient organizations, these patient groups, are going to be necessary to come forward to support that. And that's really where we're going to see patient advocates being able to support that, acting as ambassadors effectively for individuals living with those conditions, being able to do that. In the short term, at the moment, what we're trying to do is find opportunities and new ways of working for our own patient research ambassadors, our patient advocates, to be involved where we can. And obviously, it's a very challenging time at the moment. We're all focused very much on research delivery, but the NIHR is remaining fully committed to patient engagement and patient involvement where we can. In the short term, we're finding out what are the opportunities for that outside of intelligence dissemination, for example. We're aware there's a lot of information going out, which we touched upon earlier, and it's ensuring that the right information is reaching the right audiences. So it really depends effectively on local situations. I think to be involved with this is sign up to, in the UK especially, is be part of research, the online platform for advocating for opportunities for that as well, and also continue to express your interest in being a patient research ambassador. Our patient involvement teams will be able to reach out to you directly and showcase the opportunities for involvement, which are beginning to come through more and more, especially as we're seeing online tools and platforms to enable the patient voice to come together effectively, to be involved, not just in COVID research, but in research in general. So we're talking about social research and social care in other areas as well. So it's very much a movable feast, I'd say, at the moment, which I appreciate isn't the best answer, but I think it's something we're trying to rapidly mature and develop as we go on.
Okay, thank you, Gareth. We've still got 12 more questions to go, so if everybody is all right, we'll carry on with the webinar. Obviously, lots of interest. Albert, I've got a question, and it comes back to a question earlier on. Scientific publications. How can scientific publications be rapidly peer reviewed? Is there a process for making this happen in the future? Because as you say, so many papers are coming out there which are not being reviewed correctly.
Let me tell you, Nick, without wanting to take up too much time, that the area of peer reviewing for journals is a massive problem. I myself am involved in this very, very directly. I get a lot of papers to review, and I am finding it increasingly difficult to do so. Because what happens is that the main publishing houses basically use people like me as a source of gratuitous unpaid labor, and we get more and more material because irrespective of COVID, there is already a massive scientific medical literature. In my opinion, there are too many journals, just as there are too many conferences and too many of this kind of activity. And therefore, to accelerate the process is not easy. Already, in the time that I've been involved, I've seen review periods for major journals giving papers to reviewers to review, curtailed the time. They've already curtailed the time from about 4 weeks to about 1. So really, in the mainstream system outside COVID, this is already a problem. Now, for many journals, in the COVID era, this problem has basically been obviated by removing the system. In some journals, the editor himself or herself, together with a very small panel, are making very rapid decisions. In others, nothing is being done, which I find to be deplorable. I don't have an immediate solution to offer, because I think that the amount of dross which has come out is actually a minority. Much valuable information has been very quickly made accessible, and above all, freely. Because what you have to understand is that unless you are a subscriber or you are, such as myself, in a university environment, you cannot actually get papers unless you pay for them, which is another problem. It's a massive industry. Okay. So I think that making things more rapid, things are already very rapid. In fact, things are already too rapid, and in some ways there are too many things. So all this now is going to have to be very rapidly, if I can use the word, reviewed once this crisis is over.
Okay, thank you, Albert. Now, we've got 10 minutes left. I think we'll carry on up to the hour. I've got a very specific question. It was regarding, and I've lost it now. Yes, it's from regarding the need to share more information with patients. For clinical trial patients, what type of information is crucial and missing today? Perhaps Gareth and Pedro may be the best two people to answer that.
Gareth, please.
I think the difficulty of saying what information is missing isn't something we can really answer without first giving patients an opportunity to see what information is out there. So patient information sheets, a lot of the time, we don't explain. Obviously, there's a lot of regulation around. We can't say this is going to provide a cure or this is going to improve your quality of life. That's obviously the ultimate goal of these trials. What we can't do is promise, because obviously at this stage, it's still a trial. It's still an unknown factor, effectively. But a lot of the time we're saying, well, when we're having these discussions, when people are invited to provide their feedback on these documentation, to to ensure there's enough information for people to make an informed decision on whether or not they want to participate in that trial. Is ultimately, what is the purpose of that trial? What are they hoping to achieve? Not necessarily will it achieve, what are they hoping to achieve? And sometimes that's missing. The language itself, we went on to about health literacy, for example, without being patronising to individuals. We want to ensure it's easy to understand, but equally ensure that it's designed that people who have language difficulties or just a lower reading age than we may expect from a kind of an academic or clinical background, that they also have the opportunity to be able to digest that information. And we're moving towards apps, for example, or electronic consent, that bite-sized bits of information we're seeing where it's quite easy to digest, you can make that decision. And equally, the carers, partners, people who are very close to those individuals who are making that decision with them as a unit effectively, they equally have an opportunity to participate in that decision and be fully informed with that. So the best thing I can really say is, rather than us saying, this is what's missing, put together the information, give patients the opportunity to say, does this fulfill your needs, does it fulfill your requirements? Does that answer your questions effectively? And certainly at the moment, just to come back, sorry, just jump back onto the earlier question about what can I do at the moment. There's still a lot of feasibility. There's still a lot of these companies wanting to answer these questions because now they have that opportunity to ask that. The timelines have been extended so they can conduct that patient input effectively. So look for those opportunities to help facilitate those conversations too.
Okay, Pedro, do you want to give any insight into patients and clinical trials?
I agree with those needs, but I also the gap on the culture also of the collaboration with clinical trials is more wide than concrete needs and concrete. Of course, I agree with those, but in countries like Spain is so many things that we need to work on, and one of them is the accessibility. I mean, the making more close or more attractive to the people, because there are a lot of things that are a problem to participate in clinical trials, and one is regarding to the culture of participating in clinical trials. So just to that.
Okay, now we've just got about 7 minutes to go. So what I'd like to do, there's a number of unanswered questions. So if it's okay, after the webinar, I'll pass these questions around to the panelists to answer. And these will be then included in the report which is coming out. I hope that's okay for everybody, being respectful of everybody's time. So I just like to ask the panel now, as we go into the last 7 minutes or so, to summarise what they see are the 3 main points now moving forward from a short-term and a long-term perspective. Albert.
Well, clearly, we have, as I initially said, we are living still in a historical event. This is really going to change everything. I think that is rapidly sinking in. I think moving forward, patients need to, in some ways, seize the day. There are a number of opportunities. The authorities which we all engage on, whether they are regulators, whether they're policymakers, finance, reimbursement type agencies, they are needing all the help that they can get. I think that it behooves us to make very rapid and voluble representations in the way that we can do this. I think we've discussed some of these in this webinar. I'll go over a couple of points which I myself have intimated as being my main areas of interest. I think in the area of publication peer review, there are ideas coming around on how we can make things easier. I myself am in the focus of outlining these, hopefully in something which I will publish myself. In the area of clinical trials, well, we've spent encouragingly quite a lot on that, and I think that the ability for patient organizations This is done very much by some hemophilia societies in Europe, the European Hemophilia Consortium, and in particular the Hemophilia Society of Ireland, to make very direct representations to insert themselves into the process, knowing full well that especially with rare disorders, many patients know more about the issue than most normal physicians, with all due respect. So I think my summary of all this, dear Nick, is carpe diem.
Thank you, Albert. Pedro. Hola.
Okay.
Yeah.
Okay, my last point here, the connecting the situation, the actual situation, and also with the future is, of course, I am aware of the some limitation of also of the patient organization sometimes, but things have been moving the last years. As an example, I was talking previously about the patient organization umbrella in Spain. Plataforma de Pacientes was created in 2014, and we have doing a lot of things. There are a lot of things still pending to be done, as I have seen some of the comments also in the Q&A panel. But of course, these new moments needs new models and needs flexibility. And those are patient organizations ready to face them, that they are, and they are more and more than 5 years before. They are ready to be great stakeholders for new situation, because sometimes the public part, the private part, the health systems and the companies and others are just facing also flexibility in different moments. So I want to put and stress underline the value of those more developed and more ready to manage the new situations, the value they could put on the table of these new models and the flexibility needs for the future and for facing these new needs.
Okay. Thank you, Pedro. Gareth.
As difficult as time is, we have to see it as a catalyst for change and for positive change as well. We've mentioned about the collaboration we're seeing between both the life science industry, patient organizations and patients as a whole, and this new kind of uptake and awareness of clinical trials. This is really, especially from the industry as a whole, it's an opportunity to rebrand effectively, to put clinical trials into the limelight, to showcase how important they are. But equally, we need to ensure that that collaborative approach continues right through as we move forward. It's also a good, from a political standpoint, it's a good opportunity to showcase the benefits of healthcare R&D spending. We're seeing an globally increased funding into the healthcare environment. And hopefully that will continue to be the case, and we'll continue to streamline and improve our processes, both to manage global pandemics, but equally just for our ways of living. Social care, for example, is getting a new limelight shined onto it, much needed limelight as well. But hopefully we'll start seeing improvements in these areas as well. But this is an opportunity to move forward. What we don't want to see is regression at the end of this. We need to carry on moving forward together.
Thank you, Gareth. Tamsin.
Hi, I agree with Albert. We are living through a transformation event. And I also agree with Gareth that I think this is a catalyst that is accelerating some of the things that were already happening in healthcare. I think the transformation of the health systems is going to move much faster. We've been forced to do as much as we can virtually and in an online environment. So there's been a big push towards telemedicine, remote consultations, because there's been no alternative. And they were blocked for a number of reasons before. So there's the digital transformation and the use of new tools to deliver care in more useful, localized ways is going to continue. I think it's also opened up areas of collaboration within hospitals and within healthcare, because people were very siloed in their own speciality, in their own discipline and what they did. And now everyone's had to move out and learn something new and see how other teams come together. What do they do? How do they manage safety? So I think this is a really useful horizontal thing that's had to happen across health and got people out of their silos. Much needed. We've been talking about it for years, never been able to make it happen. COVID-19 might have been the catalyst for change. There's also, within the overall focus of the health system environment, governments have woken up sharply to how critically important their life sciences industry is to them and to their national security. So I expect to see a lot more government interest, and not just from the health department or even the education department, from the defense department, from the treasury, from the Ministry of Finance, on how do they cluster and build and strengthen life sciences. And that goes beyond just medicines. It's also going to involve devices, but it's also going to involve new forms of innovation. So I think there'll be suddenly health systems and their manufacturing is going to be a key thing that governments are going to want to invest in and see happen on their territory, not just part of global supply chains. And the final element I want to leave you all with, which is a bit of an open question for me. For years, we've had problems with vaccination. In Europe, we're exporting measles problems back to the rest of the world. We have historically high levels of mistrust in the vaccination process. The only way to get out of the lockdowns we're in now in the future is going to be a vaccine. That's our big hope. But there's been a survey in France saying a quarter of the population wouldn't take it because they distrust vaccines. If your ability to leave your home and go to work is affected by whether your neighbor is prepared to get a vaccine, this is a very different conversation about the relationship between individual choice and public good. And I expect to see that become an even hotter, broader debate in the coming months. And I leave you with that hot topic.
Okay. Thank you, Tamsin. And I've been making some notes during this, and my three sort of take-home messages that this whole COVID-19 is going to create a more informed understanding of the importance of the emotional burden of disease, particularly social isolation, mental health, a subject which is very often neglected by regulators and HTA. The patient groups with whom we work will be at different places in the transition to the new norm, and we shouldn't assume we know where each of the groups are. They'll all be in very different places. In industry, we're going to need to use appropriate supportive strategies in helping the patient groups make a successful transition, and that digital communication is going to become a far more new way of working, especially in clinical trials and patient engagement, and that we must make sure that the learnings we've already had over the past years in patient engagement are not lost, but they're used in moving forward. That's I think we're at the hour now, so I think it's probably a very good point to end, unless any of the panel have got any other further comments to make. I'm not hearing anything. So what we will do is that we'll answer by email or in the report any of the outstanding questions. And I'd just like to thank, first of all, all of the panel, Albert, Tamsin, Pedro, Gareth and Paul, who's been in the background making sure everything works smoothly, for speaking on this such an important topic. And also for all of the people out there who I'm sure have had quite a lot of webinars, and thank you very much for the time you've allocated to listen to this subject, which we hope you found useful. And on exiting the webinar, do please finish the answer the 2 questions. Thank you very much, everybody.
Thank you, Nick.
Oh, thank you.
Take care. Bye. Bye-bye.
Yeah, stay tuned. Bye now.